Dr. Carroll, I know he's from Stanford, and I've seen him speak live, and I've also watched him on YouTube several times, and he has opened up a whole new world of headache to me that I didn't even really know existed. So everybody, you're going to want to take notes, and you're going to want to watch his lecture over and over and over and over, and keep on digging, because we can really help some people with what he's doing. And he's got also, I think he has a Dropbox that I found once that has a lot of literature in it as well to back up anything that you're trying to investigate. So Dr. Carroll's from Stanford, and you can look at his bio in the program book or online, and he's going to tell you all about his life in headache. He's actually a pain management doctor, is that correct? And he's on faculty at Stanford, and now he just does this. So he's going to give us a talk about spinal CSF leaks, or mystery headache.
I want to say thank you to Christina. I think a wonderful thing and a real resource here in Jackson. So thank you to...
The talk that he's given is actually highlighted in the National Headache Foundation magazine, and I have some extras for y'all to grab after this lecture.
Excellent. So thank you, Christina. We're going to be talking about spinal fluid leaks today. I have no disclosures or conflicts of interest. The work is supported by the Considine CSF Leaks Fund at Stanford from a grateful patient. Let's talk about spinal fluid. So the buoyancy of the brain is maintained by the spinal fluid, and it causes the weight of the brain to be reduced functionally, essentially 96%, reducing the weight of the brain from about 1,200 grams to 45 grams. And the thought is that basically the brain's made out of fat. Fat's lighter than or less dense than water, and so essentially the brain is floating in its own little swimming pool of water. And what you see here is that that fluid goes all the way from the skull down the spinal fluid. It's white here, all the way down to the tailbone. And anywhere where the bag gets torn or disrupted, the fluid can start to leak out, and the brain up here starts to sag down just a little bit and cause head pain. Some thought is that the head pain arises from traction on pain-sensitive structures in the skull, including the meninges, and other people believe that the mechanism for the pain is actually that as pressure inside the skull is reduced, the veins and the arteries distend, and that it's the vascular distension that causes the pain. No one knows for sure. It does seem apparent that people with spinal fluid leaks get some degree of relief from triptans, which have a known vasoconstrictive effect, and so at least temporarily they get some relief. And whether that in fact indicates something about the mechanism of the pain is yet to be determined. So the spinal fluid is contained by a watertight bag made out of something called dura. And the dura is made of connective tissue, and it can be real thin, and potentially this can break or be torn. And it's made out of connective tissue, and so people who have hereditary disorders of connective tissue are more likely to develop spinal fluid leaks, and we're going to talk a little bit more about that as we go on. It can be torn by trauma. We'll talk about how whiplash has been associated with spinal fluid leaks, and it can be torn or punctured by sharp edges, including bone spurs, needles in the hands of a well-meaning doctor, scalpels in the hands of a well-meaning surgeon, and screws as well. And the symptoms of a spinal fluid leak are really more than headache. Headache is the most recognizable feature. So when local anesthetics were invented in the late 1800s, shortly thereafter they discovered that if they injected local anesthetics into the spinal fluid, that people would get what's called now spinal anesthesia, where they'd become totally numb in the lower half of their body. And shortly thereafter, they realized that some percentage of people they did that to would develop this strange and unique kind of headache afterwards, where they would feel much better when they were flat, and they would feel worse when they were upright, and they called this a post-dural puncture headache. And they made the correct inference pretty early on that this was caused by leaking spinal fluid. And for the next 60, 70 years, they did not know what to do about it. In the 1930s, a neurosurgeon in Germany named Schaltenbrand made the observation that some people who had no history of a dural puncture had the same syndrome. this headache that felt better when flat, worse when upright. And he made the correct inference that it was due to a deficit of spinal fluid. At the time, he thought it was actually due to a deficit of production of spinal fluid. There's never been any evidence to suggest that people with these kinds of orthostatic headaches, headaches that are better when flat and worse when upright, can be caused by a deficit of production. We now know that the people who have this as a spontaneous phenomenon, not one caused by a doctor with a needle, but just having it arise on its own, in fact, have developed spontaneous spinal fluid leaks of their own. The headache that they develop, often when it first starts, it has a clear postural component. But as time goes on, that postural component can change character. So if you've worked, as I have, as a teaching physician at a teaching hospital that teaches pain management docs how to do things like spinal cord stimulators, you've had the opportunity from time to time to teach fellows who are new at putting in spinal cord stimulators how to do this, and they will occasionally puncture the dura with a rather large needle while they're trying to put in a spinal cord stim lead. And in that circumstance, because they have a new lead in their epidural space outside the bag of fluid, we're often reluctant to patch it right away for fear that we might contaminate the lead. And so we often let them just have this leak for several days. And what you see is on the first day, a very clear orthostatic headache, where they're better when they're flat and they're worse when they're upright. And the second day, that's also true. By the third day, they're not really feeling that good even when they lay flat. And the longer that goes on, the longer they have to be flat before they start feeling well. And the orthostatic nature of the complaint starts being kind of muddled and muddied, and it's not clear that it's really better when flat and worse when upright. And as a consequence, when people have spontaneous leaks, not only is there well-documented cases of this clear orthostatic headache where they're better pretty quickly and they're worse when they get up pretty quickly, but it's clear that many people have what we call a second half of the day headache. So after 8 hours of being flat at night, they wake up, they feel pretty good. And then when they get up, things start getting worse the longer they're upright, so it can be a second half of the day headache. And one of the important questions to ask people with headaches is, does your head hurt before you get up and get out of bed? So when you wake up, before you get up, how are you feeling? We've also seen thunderclap headaches that mimics subarachnoid hemorrhage with CSF leaks. One of the most classic presentations is one that mimics occipital neuralgia. People tend to have a sense of pressure bilaterally in the back of the head, but the occipital nature of the headache is not a reliable characteristic. We see people with unilateral temporal headaches from this. But the most characteristic is a bilateral kind of occipital, suboccipital pressure type sensation, sometimes radiating to behind the eyes. And so one of the diagnoses that often gets made instead of a leak is that someone has bilateral occipital neuralgia. That's a diagnosis that I would encourage you to be somewhat skeptical of. The occipital nerves are important causes of pain in the head. Occipital nerves can, in fact, be trapped either as they're exiting the C2 nerve root or as they're passing through this muscle called the semispinalis capitis muscle. But it's unusual for the same nerve to be bothered on both sides of the body all by itself. The presence of bilateral occipital pain should really prompt you to look hard for a leak. People with spinal fluid leaks also complain of significant fatigue. This is less well documented in the literature, but you'll see people who have spinal fluid leaks, and when you patch them, their parents come in and say, you know, my daughter's running around the house. I haven't seen her like this in years. Neck pain, almost everybody with a spinal fluid leak, including people who have leaks down in their tailbone, will have prominent neck pain, neck stiffness. Nausea can be profound. Many of these patients walk around with Phenergan and Zofran in their purse, often nauseated all the time. We had one patient who had a leak after having one of these spinal cord stimulators gone awry, who lost 50 pounds over the course of a year from a leak that we could not find until she had her third myelogram. We kept looking for it. It was terrible. Ultimately got fixed. Tinnitus, very common, maybe 80% of leakers, is one of those things you should not see tinnitus in someone who has occipital neuralgia. There's no reason that pinching the occipital nerve should cause someone to have ringing in their ears. And this is kind of to denote what I call neurologic weirdness, the constellation of symptoms from dizziness to lightheadedness to deficits in memory and concentration. I've had patients tell me I was driving home from my daughter's ballet recital where along the way I've driven every day for 10 years and I couldn't remember what exit to take. Suddenly I was disoriented. I didn't know where I was. So there is the well-recognized post-dural puncture headache. Comes from a single leak low in the thecal sac, the bag of fluid, resulting in that clear orthostatic headache that's better when flat, worse when upright. 90% of these get better with a single epidural blood patch. The natural history of this is understood. It's mostly benign. Many people with this get better all by themselves, even if they don't get patched. But we'll show some data that suggests that the likelihood of getting better all by yourself is perhaps a little less than we expect. This is rarely mysterious. We know that young women are most at risk for this, and it's fixable. If you patch them, and what that means is injecting blood or glue outside the bag of fluid where the leak is, they get better. In contrast, in people with spontaneous leaks, there's documented papers that as many as 30 to 40% have leaks at more than one site at the time of diagnosis. And this may reflect either one of two things going on, that if you're prone to a leak because you have Ehlers-Danlos or Marfan or some kind of hereditary disorder of connective tissue, that manifests as multiple areas of the dura that are attenuated or weak and prone to having a leak. And maybe you tolerate one leak so-so, but you're driven to treatment if and when you then fall on the stairs and you develop a second leak, and now you're losing spinal fluid at a faster clip. Or alternatively, I'll show you some evidence that people often develop these leaks after a whiplash accident. Maybe when you hit the steering wheel or you hit the seatbelt at 30 miles an hour, that pressure wave that goes through the bag of fluid, anywhere where there's a little weak place just pops, and there you go. In contrast to the 90% response rate to a single epidural blood patch, well documented that with a spontaneous leak, the likelihood of being fixed with the first patch is only 30%. With repeated patches, that appears to go up to 65, 75%, with the remaining 25 to 30% possibly requiring surgery, which seems to only be able to help about half of those. The natural history of this is poorly understood, often marked by chronic disability. We've seen a number of people who we fixed with patching who told us, I had these symptoms all through high school, and then during college, I had a few years where I was pretty symptom-free, and then they came back this day in my junior year of college. And so we infer from that there is some natural propensity in some people with leaks to seal on their own, although this is not well documented because when you document a leak, it's such a disabling condition, few people actually choose to decline treatment and just live with it so that the natural history can be documented. Almost all the time when we make the diagnosis, we actually treat it. Unlike this, where the big risk factor is young women, this is hereditary disorders of connective tissue. But what they hold in common is that both of these things are fixable. And so you can help someone go from living with chronic disability to actually feeling well again in a durable way, which is a really profound thing. So one of the objectives here is to help the doctors learn that CSF leaks are not rare. The best estimate of the incidence of CSF leaks comes from a study that they did at Cedars-Sinai in LA, where they have a treatment center for people with CSF leaks. It's run by Wouter Schievenk, a neurosurgeon there who's really a luminary in the field. And what they did is they looked at imaging studies that were done in the ER of every person who came in complaining of a headache that got imaging studies in the ER over a 3-year period. And they identified retrospectively, going through these studies, 11 cases of people who had evidence, MRI evidence, of a CSF leak on their brain MRI. During the same time period, they counted the number of people who presented with subarachnoid hemorrhages. And what they found was they were able to count 11 cases of spontaneous leak and 22 cases of subarachnoid hemorrhage, leading an estimate of incidence of, I believe, 5 per 100,000. And I'll show you how that compares to other conditions. But the important thing is, nobody would tell you that someone with a thunderclap headache can't have a subarachnoid hemorrhage because it's too rare. And in fact, the incidence of a CSF leak is about half of that. So if you have seen in your course of your career 10 subarachnoid hemorrhages, statistically, you should have seen something around 5 spontaneous leaks. And if you find, in fact, that you've diagnosed a number of subarachnoid hemorrhages and you have not diagnosed any CSF leaks, that suggests that you are having them come in and out of seeing you at the office without making the diagnosis, and that should give you pause. So what is 5 per 100,000? Well, the incidence of esophageal cancer is only 4 per 100,000, and you would never tell someone who couldn't swallow without choking on their food they didn't have esophageal cancer because that's too rare, and you would never tell a mom who was worried that their teenager might commit suicide that they shouldn't worry about that because it's so rare. And what you see is the incidence of CSF leak is squarely in between these two on the same order of magnitude. So the idea that it is so uncommon and that should dissuade you from making the diagnosis is not borne out by the data. So what causes people to leak? There's really 4 things. That their connective tissue is not right, that they've had some kind of whiplash accident, there's a bone spur or some other puncturing thing happening to the bag of fluid, or that a well-meaning doctor has stuck a needle in there and not appreciated that their needle hole may continue to leak and leak and leak. So one of my colleagues, Pam Flood, while at Columbia on the obstetric anesthesia service, was wondering how people did after they had an accidental dural puncture when they had their epidural placed for childbirth. When they do an epidural for childbirth, the intent is to put the needle just outside that bag of fluid, thread a catheter in. But the rate of unintended dural puncture is something like 1%, even in well-trained hands. And so we know that there is some regular incidence of post-dural puncture headache after an epidural. What had been poorly documented was the long-term consequences of that. So she looked at 40 cases of people who had had an epidural and a known dural puncture, and 40 cases of people who'd had an epidural for childbirth at the same hospital who had not had an accidental dural puncture to act as a control. And what she found here is that among the 40 control patients who had an epidural, same hospital, had gone through childbirth, the rate of new chronic headaches diagnosed 12 to 24 months later was 5%. That's the baseline no dural puncture rate, 5%, okay? If you had a known dural puncture and you were followed and ostensibly treated correctly for it, the rate of having new chronic headaches 12 to 24 months later, 28%, all right? Almost a third. Now, if you had a blood patch, i.e. you were not managed conservatively, they recognized you had a dural puncture, they decided they were going to do something about it, they put a needle in outside the bag of fluid, injected blood, your rate of having new chronic headaches a year later is still 4 times the background rate, okay? So if you got a dural puncture and you were treated ostensibly with a 90% effective intervention, a blood patch, your rate of having new chronic headaches is still 1 in 5, and it's 4 times higher than the background control rate. If you were managed conservatively, which means that they hydrate you, they give you caffeine, and you say that you're feeling better, the rate of having new chronic headaches, because you didn't get a patch because you were telling your doctors, I think I'm okay, or they thought maybe your headache was no longer a postural headache, and so they sent you out, even though you had a known dural puncture, by day 3 or day 4, you're saying, yeah, I've got a little head pressure, but it's not worse when I stand up. They say, oh, you know, it's probably just a migraine, you're not getting any sleep, you have this new baby, you're a woman, and so you're complaining anyhow because we do this to women in this country. And so if, in fact, you do that and you fail to offer that treatment, the new rate of chronic headache is 40%, 8 times higher than the control rate, all right? If you multiply these numbers, if you believe these numbers, and you multiply them by the number of epidurals and wet taps in this country, this suggests that there should be a lot of people walking into headache clinics who are complaining of headaches that actually date to this. So Pam Flood first published that This was validated by another study, much larger, again, case control study, now looking at 308 patients, looking again at the rate of new symptoms a year after unintended dural puncture. And again, look at headache here. The background control rate among people who did not have dural punctures, 2.1%, a little lower than the study reported by Dr. Flood. But again, this third of patients, 34%, very similar numbers to Dr. Flood, validated in a different study, larger study by a different set of investigators, same data, suggesting this is a real finding. And there are studies underway now, including one at Stanford, to validate this prospectively. This is a young woman who, at the age of 19, came into Stanford Hospital to have hip surgery. You could ask, why does a 19-year-old need hip surgery? Maybe there's something not quite right about her connective tissue, and she was more prone to having a little arthritis in her hip. She wound up in the recovery room after her hip surgery reporting severe pain. They tried to treat it with Dilaudid. She was still screaming. They decided to offer her a post-operative epidural to manage her pain. They rolled her on her side. They tried to put in an epidural, and they wet tapped her. They knew they did it. So they took the catheter out, and the pain service at Stanford saw her the next day and said, you had this dural puncture yesterday, you might be having some headache, we can do a blood patch to help you with that if you'd like. She remembered the great discomfort of having the epidural the night before. She had been flat in bed because she just had orthopedic surgery, her headache wasn't that bad, and she declined the blood patch. The pain team told her, no problem, if you change your mind about it, let us know, we'll come back, we'll give you a blood patch. So she was preoccupied with the pain in her hip, she forgot about this dural puncture, but as her hip healed over the next 4 to 6 weeks, it was really the headache that was debilitating, and she'd forgotten that she'd ever had a dural puncture. Remember that she'd been loaded up on narcotics at the time, both that they did the dural puncture and when they offered her the blood patch. So she really wasn't remembering things all that well. She's in the hospital environment where you have so much new information coming at you, it's hard to really retain things. So she did not realize that her symptoms were from a dural puncture. And she wandered into the pain clinic at Stanford asking for help with her headaches 18 months later. And it's only because the doctor she saw there, not me, was particularly thorough and was able to kind of document, oh, this started around the time of your hip surgery. Oh, I see here in your medical records that they had a known dural puncture. You never got patched for that? No. Okay. So this is her MRI. It was read as normal. People who do a lot of this will note that the pituitary is a little generous, but you sometimes see that in a young woman. The upper border of it is convex up. One of the signs on an MRI of a dural puncture is pituitary hyperemia and enlargement. The mnemonic for that, by the way, is SEEPS. I'll mention it to you for those of you who are looking at the MRIs yourself, popularized by Dr. Shivink. SEEPS, S-E-E-P-S. The first S is for subdurals. You'll see subdural hygromas, subdural hematomas on a minority, but on some MRIs of the brain in people with intracranial hypotension. The first E is for epidural enhancement. Often you'll see enhancement of the meninges. You'll see enlargement of the veins. That's the second E. The P is for pituitary hyperemia and enlargement, and then the last S is for brain sag. No real brain sag here. The cerebellar tonsils aren't sticking down. It's not Chiari-esque. Really, the only thing that looks suspicious here is the pituitary. But again, that was read as normal at Stanford. After her first blood patch, she had transient relief. After her second blood patch, she was fixed. This is what she looked like. She was very happy. But I think in most of the country, let's say she hadn't wandered into our hospital with her headache. Let's say she'd gone down the road and wandered into UCSF and they didn't see our records. She didn't connect it to her dural puncture. She'd have never had that diagnosis made. She'd be getting treated as chronic migraine right now. Why are genetic disorders of connective tissue risk factors for CSF leak? Well, your bag of fluid shown here on a coronal section of a CT myelogram, this is the gray stuff here is the spinal fluid with contrast in it. These are the pedicles of each vertebral body. This is up in the neck. And what you see here at this level are these little sacs that are full of contrast. And on this side, it's kind of a little bilobed sac. All right? These are essentially thecal sac aneurysms. In the same way you can have an aneurysm of a blood vessel in your brain, you can have little aneurysms on your thecal sac. And they either go unreported on the read of the imaging most of the time, or they may be described as either a meningeal diverticulum or a perineural cyst. But in fact, calling it a perineural cyst does a disservice to all of the treating providers that may read that report, because you don't think of a cyst as related to the problem you were looking for, which was a leak. On the other hand, if they described, oh, we don't see clear fluid leaking out, but we see an aneurysm of the thecal sac in someone with a good story for a leak, you'd say, whoa, that's kind of an interesting finding. And this is it blown up here. See these little bilobed cysts, aneurysms. And here's someone who had a CT myelogram at the base. So this is their lumbar spine, and at the base of their lumbar spine, blown up here, you see what's called a Tarlov cyst, which is the same thing, but at the bottom of the bag of fluid. And you can see that even this very large Tarlov cyst has on itself its own little cyst, right? And so what happens is a little place where the bag of fluid has an area of weakness, starts to distend. As it distends, it thins out, it becomes progressively weaker, and it kind of develops into this aneurysmal structure, just like a blood vessel aneurysm. And then one day, someone like this falls on the stairs, and this Tarlov cyst that had been causing no problem at all in and of itself starts to leak, and suddenly they have bilateral occipital neuralgia, or they're diagnosed with Chiari, or they're diagnosed with POTS. Another way that a hereditary disorder of connective tissue can hurt you is you wind up with diffuse degenerative changes. So not only is your dura weaker and more likely to have these aneurysms, but you get diffuse disc disease, which is not all that uncommon. And if you look at this, almost every level here has degenerative disc disease, and some of these levels, if you look here, and I've blown up one of them here, the discs actually can calcify and give you little sharp-edged calcified projections into the front of the thecal sac. And so, the people with bad connective tissue, they're prone to having these aneurysms, which can pop, and they're prone to developing this kind of diffuse disc disease that can then calcify and puncture. And even worse, someone like this is at some substantial risk of having some well-meaning neurosurgeon go in there and do a fusion or something like that. And then their tender dura, which is weak anyhow, is going to have various bones ripped off of the outside surface and screws put in within millimeters of the dura, and so they're more likely to get those kinds of surgeries, the imaging of which afterwards is not good. When you have instrumentation put in your back, the ability to find a fluid collection goes to crap. Okay, that's a medical term we use at Stanford. All right, so how do you know your connective tissue isn't right? Well, you have signs and stigmata of this, and one of the most important signs is just benign joint hyperflexibility. And so this is one of the first people that we saw after we reached out to the POTS clinic at Stanford and said, hey, if you see someone who has POTS, but they also have Ehlers-Danlos and headache as a big part of it, we'd like to work them up for a leak. And this was the first person that they sent over, and evaluating her for hyperflexibility, I asked her, can you do any weird double-jointed things? She's here touching her forearm with her thumb while she crosses each finger over the other one. And you can see how far back this patient's bending her finger. I had a medical student come in complaining of headaches who, as a nervous tic, I wasn't trying to ask him about being hyperflexible. While he's sitting there talking about his headache, he's bending his finger backward like this. All right? That's a giveaway. When someone comes into your clinic talking about headaches while they're doing this to their finger, you should think about a leak. It's a giveaway. All right. Other things that you'll see with hereditary disorders of connective tissue, you'll see things like early development of cataracts. Often these patients are very good at dance or gymnastics. They're much more flexible than their peers. They remembered being more flexible, especially when they were younger. It turns out when you have these hereditary disorders of connective tissue and can do these kinds of things, often that goes away as you get older, and so you can lose that excessive flexibility after you get over age 35, but the younger patients will have it. You'll also see things like scoliosis, a pectus excavatum, a history of joint dislocations. often diffuse, people who have bad connective tissue often have diffuse musculoskeletal pain. And so when someone comes in and they hurt kind of in this joint and that joint and this joint and that joint, and especially if they're a woman and they're young, what do they get diagnosed with? Fibromyalgia. There you go. Good. All right. We're all on the same page. Those disorders of connective tissue can sometimes, in the long bones, cause those long bones to fuse later. The fusing is delayed because the connective tissue is a little abnormal, and as a result, people wind up unusually tall. This is someone with what's clearly kind of a Marfanoid status. But the headache patient who is tall and lanky is a suspicious character for a leak. Bone spurs also cause leaks. This is the CT myelogram of a patient in whom a T3-4 bone spur caused a leak. You see it here. Very nice on a CT myelogram where you can see the spinal fluid here around the spinal cord, which is here. You have this little disc calcified projection projecting right through the front surface of the bag and actually contacting the cord. What you do not see is anything that a neuroradiologist would call a leak. This was read as negative by the neuroradiologists at Stanford, and it was only after I sat down with them and said, this person has an exceptional story for a leak. It's perfect all the way around, and the brain MRI is a little suspicious. I'm going to offer her a patch, but I'm not sure where I should be patching. Don't tell me if there's a leak, but tell me if you were patching, where you would patch. That's when they started focusing on this. And so that can be a very valuable question for your neuroradiologist. Not do you see a leak, but if you were going to patch, where would you patch? And in fact, what you see here at the cut above this, the slice above this on the myelogram and the slice below, is this little kind of contrast out along the nerve root. Here and here. This was not read as a leak by the neuroradiologist, but I'll tell you, you don't see that at any other level on the myelogram. They say sometimes we just see this in people with myelograms, and we don't think anything about it. True story. They look at that, they say, we just see this sometimes. I don't know how many times when they're just seeing this, it's really someone who's leaking. This is, by the way, what it looked like on an MRI. Can't tell at all that that disc is calcified on an MRI. And it doesn't look particularly sharp on the MRI because the MRI doesn't have that degree of anatomic detail. Much better anatomic detail on that CT myelogram. You really can't tell that there's more fluid leaking out here on the MRI. And on the sagittals for the MRI, it looked like this. Just a regular old disc, all right? So the idea that you're going to diagnose this based on an MRI and not need your CT myelogram, good luck to you. Because if you decided to stop at an MRI in this patient, you'd have never gotten to the right diagnosis. And she'd still be walking around having occasional seizures, passing out when she was up too long, basically totally debilitated. Never would have gotten to the right diagnosis without a CT myelogram. Here's a gentleman who came to visit me from South Africa. He told me the craziest story about how the longer he was upright, the more disoriented he would become. He didn't really have a lot of headaches. He had a lot of neck pain. But the longer he was upright, the more disoriented it would become. And we all have narratives to explain what we're experiencing. His narrative was it started while he was working on a specific construction site, and he thought that there was maybe a carbon monoxide leak at the construction site, so he thought he had some kind of chronic carbon monoxide poisoning. You know, just the story is just telling you he's crazy. But every morning he was well, and then as the day went on, he'd become more and more disoriented and have more and more neck pain. You can see that he's had a previous fusion here, and at the level above the fusion, he has this, a little calcified disc osteophyte, which I've blown up here so you can see it better, contacting and pushing in on the front surface. Doesn't look particularly sharp on this sagittal image. This is what it looks like on the axial image. This little focal bony projection poking right in through the front surface of the bag of fluid. Here's the cord, which is being, in fact, slightly deformed by it. This myelogram was read as showing no leak. You can all see that, in fact, much like our other myelogram, there is adjacent to that osteophyte some contrast along the nerve root, which they just see sometimes. So that was not read as a leak. And, of course, his story was kind of crazy. I was almost initially going to not do the myelogram until he stood up at the end of the visit And he towered over me. I'm 6'2". I didn't realize as I was talking to him that he was 6'6". And then so he's telling me this crazy carbon monoxide story. I was like, yeah. And then he stood up and I was like, okay, you're getting your CT myelogram. And that's what we found. This is from a patient, another bone spur, this time coming off the lamina, poking right into the back surface of the bag of fluid. You see this little kind of contrast thing here. Again, we just see that sometimes. It was read as negative by the neuroradiologist at Stanford. You see a little contrast maybe streaming off on this side too. She had been diagnosed as Chiari, had had her skull base opened up at UCSF, then had been diagnosed as having neurocardiogenic syncope because she was passing out when she stood up too long. Went into SVT, had a cardiac ablation because of the persistent tachycardia. So she's given all these diagnoses, Chiari, neurocardiogenic syncope, SVT, when in fact she had this. I'll show you what she looked like after we patched her. Here's another bone spur came in and someone diagnosed with POTS. All right, so the other thing that can cause leaks often that gets overlooked is trauma and whiplash. Here's a study that came out of Japan almost 10 years ago now. Epidural blood patch therapy for chronic whiplash-associated disorder. What's whiplash-associated disorder? Well, apparently in Japan, if you have whiplash and you develop chronic neck and head pain associated with fatigue and difficulty with memory and feeling intermittently foggy and fatigued, they call it whiplash-associated syndrome. And what they did is they identified 66 patients with whiplash-associated disorder, and they gave them all a study called a radionuclide cisternogram. What's a radionuclide cisternogram? It's a study in which a doctor injects radioactive tracer into your spinal fluid and looks and sees if they can see it leaking out anywhere. And what was really stunning about this is that of the 66, 36 were found to be leaking. Imagine if half the people who are dealing with whiplash-associated neck and head pain are actually leaking. So this is the percentage of people who are working before the accident, okay? So before the accident, they're almost all working full-time. Before their epidural blood patch, essentially, they're all on leave. And after getting patched and treated, half of them are back at work. This will tell you, this isn't just a headache. These people are disabled. And this is what a radionuclide looks like. The radionuclide cisternogram looks like before and after. So you see a couple things here. You see the tracer here not having spread up as well as on this side, where the tracer has spread throughout. And the other thing you see is the tracer is kind of spreading out along the nerve roots, these little nubbins, right? Just like we see on the CT myelogram. So, and then the other thing that you see is tracer accumulating in the bladder here. No tracer in the bladder here at all. And the thought is that when the tracer leaks out of the spinal fluid, it gets picked up by the vascular system and the venous system pretty quickly, where it then gets filtered by the kidneys and gets put into the urine. And so seeing tracer activity in the bladder before 3 hours is a really good sign that there's a leak somewhere. But it doesn't tell you where the leak is. But it's pretty good at telling you that there is a leak. And I will tell you, even at Stanford, and that's well described, well published, but at Stanford, often they will not, in fact, call that unless you say, was there early uptake in the bladder before 3 hours? They will sometimes not comment on it as being a positive study. And we've had to bring the papers talking about that as a positive finding to their attention multiple times. They're getting better about calling it positive when they see it, but they still don't call it positive every time. Here's another patient, same kind of story. Again, the stuff leaking out here, contrast in the bladder. This is what it looks like afterwards, after being patched and fixed. So what about other imaging? So you cannot believe how many times I've been told by the radiologist that MRI is a sensitive study for finding a leak. And they often will quote at me this paper, done by some very good doctors, Dr. Starling. David Dodick, I think, is probably well known to some of the people in the audience. Where what they did is they looked over a 12-year period at people who had orthostatic headaches at their institution and identified people who'd had positive CT myelograms showing leaks and had also had MR myelograms, a kind of MRI used to make the spinal fluid really pop out so you can see a leak well. I will note to you that of the CT myelograms that were positive, none of the CT myelograms I've shown you would have counted. Okay? None of those would have counted as being positive. All of those were read as negative because they didn't show a distinct bounded fluid collection. So they're talking about the most positive of the positives, things where like a bounded collection of fluid was found, and then they did an MR myelogram. And so here's what they found. They identified over that 12-year period 12 patients who had both of those imaging findings, or both of those imaging techniques done. So of the 12 who had CT myelograms that were positive, 11 had positive MR myelograms. Okay? What does that tell us about the likelihood that an MR myelogram is going to be positive in a patient who's coming in off the street? It doesn't really tell you a lot. What it tells you is that MR myelogram results are correlated with CT myelogram results, and it tells you nothing about the underlying sensitivity of both of those studies. It tells you nothing about how many leaks were in fact missed during the same time period. To know the sensitivity of the study, you need to know during that same time period where they had these 12 positive studies, how many were really leaking and were read as negative. That's what you'd need to know the sensitivity. But given what they did, you can't know that at all. So what they did is instead of saying, this is the sensitivity of MR myelogram, they said, when compared with the gold standard of CTM, CT myelogram, MRI of the spine appears to be sensitive and less invasive, and they said it was 91% sensitive. All right, so if you read, they're kind of hedging. Why? Probably because when they sent it into the journal, they said, well, you know, we want you to report sensitivity, and they really couldn't report sensitivity, so they said, well, if we said that the CT myelogram finds everything, then we could say that the MRI is actually 91% sensitive. But they really, you know, this really isn't telling us what the underlying sensitivity is, how many leaks get missed by MRI. And so it's a disservice to think about this as sensitivity. You should not stop looking because your MRI did not find a leak. So here is what I think is the best study trying to get better at figuring out just how sensitive these studies are. So this came out of Japan 4 years ago, where they have a consortium of 11 hospitals trying to work together to identify people with spinal fluid leaks, and they collected 100 patients with orthostatic headaches prospectively. So based on clinical criteria, they thought these people might have leaks. They had orthostatic headaches. They felt better when they were flat, worse when they were upright. They collected 100 of them, and they gave them all kinds of imaging. So of the 100, 89 got a brain MRI, with and without contrast. Of the ones that got the brain MRI, 20 were read as positive. And of the 69 that were negative, we don't know how many of those were false negatives. Okay? But at least we know that if you present with an orthostatic headache that the neurologists think might be a leak, you know, if you looked at 100 patients like that, all of whom seem to have equally good stories, only 20 of them actually have positive brain findings. They also, 89 got radionuclide cysternograms, 70 got axial T2 spine MRIs like I showed you, and 86 got that MRI myelogram. Of the 86 MR myelograms, only 3 were positive. Okay, so the MR myelogram missed at least 17 of the brain imaging confirmed leaks. 17 of the 20 were missed on the spinal MR imaging, MR myelography. 14 were found, but still 6 were missed with the axial T2 spine MRI. Reading their paper, you can't quite make out how many had positive radionuclide cysternograms, but all told, there were, I think, 16, it's not showing up on this one, people who had actual positive spine imaging. We don't know how many of the 84 were false negatives. Again, we don't know how many of the 84 were missed, leaks, people who are really leaking. So the sensitivity might be as low as 16%. Now, when you looked at overall the correlation between positive brain findings and positive spine findings, 7 of the 20 brain positive imaging, people who had distinct intracranial hypotension on their brain MRI, 7 of those patients had no sign of a leak on any of these modalities of imaging the spine. all right? So the idea that you're going to rule out a leak with any one of these studies is, I think, really fraught. We have no idea what percentage of leaks are actually missed by our current imaging. And 7 of the 20, we said 35% were missed on multiple spine imaging. So how are we going to try and get closer to the truth of when someone's leaking? I want to tell you a little bit about opening pressure. Many people will try to use an opening pressure, the pressure of the spinal fluid when you stick a needle into the spinal fluid and then hook it up to some clear plastic tubing. The higher the fluid rises in the tubing, the higher the pressure is in the bag. And people will use that to try to determine if there's a leak. This is something that for years people said an opening pressure less than 6 centimeters of water meant you had a leak. In fact, a normal opening pressure is between 6.5 and 19.5 millimeters of water, so 6 to 20 centimeters. But the group at Duke that has a center looking at people with leaks published something last year showing that if you looked at people who had negative studies for a leak and positive imaging studies for a leak, there was no actual difference between opening pressures between those with image-proven leaks and those with negative studies for leaks. No difference in opening pressure. And in both groups, the opening pressure on average was in the normal range. All right? So they're in the process of rewriting the American Headache Society guidelines for how to diagnose intracranial hypotension. And it's probable that they're going to remove the reference to opening pressure. It's now thought to be not at all reliable for excluding a spinal fluid leak. Now, if you have an opening pressure of 0 or 3, it's probably a leak. This is probably a specific test. It's probably true when positive, but not so informative when negative. Another study of documented leaks, 5 of 17 had normal opening pressures. So again, depending on how you grab your patients and how you find them, you're going to have differing percentages, but consistent studies showing that an opening pressure is not a sensitive way to rule out a leak. So useful if low, but a normal opening pressure does not rule out a CSF leak or mean that orthostatic symptoms are POTS, because that's what we often see is somebody has orthostatic symptoms, they have a headache that's worse when they're upright, their imaging is read as negative, their opening pressure is normal, and they're told you have POTS. What else can we say about labs? We actually find the total CSF protein in the spinal fluid to be pretty useful. And a number of studies have found that roughly half of the people who have spinal fluid leaks have elevated spinal fluid protein, with their cell count and their glucose being normal. And the thought is that if you have spinal fluid leaking and your intracranial pressure is low because of that, you get a kind of diffusion of plasma from the veins across the venous tissue into the CSF, carrying with it proteinaceous fluid that raises the spinal fluid protein. And in our experience, something like half of the people, not only are there the studies that suggest that maybe half of the people with spinal fluid leaks have elevated CSF protein, and that on average their CSF protein is elevated, we found similar numbers, that maybe half of the people who give us a really good story for a leak have elevated spinal fluid protein. And it tells you you're not dealing with common migraine. There ain't no occipital neuralgia in the world that's going to give you an elevated spinal fluid protein. In fact, there is a long list of things that will give you an elevated spinal fluid protein, but almost all of them make you really sick really fast. There are a number of dreadful things that give you elevated spinal fluid protein, but most of the people we're seeing walking into our headache clinics are not dying. They've had it for a long time, and there's not a lot of things that give you elevated spinal fluid proteins for a long time without you developing something dreadful. So when you see someone who comes in with this, you should think about a leak. And I'll tell you what these people get diagnosed with. What do you call someone who walks in with a severe headache, they get spinal tap to look for meningitis, and you find an elevated protein, but their cell count is normal? What do you diagnose that person with? Sometimes CIDP, sometimes aseptic meningitis. All right? All right. So this was the first patient, KG, who was sent to us from the POTS clinic when we reached out to them, wanting to see if any of their patients were really leaking. Her CT myelogram showed this kind of contrast spread along the nerve roots in the neck. Her MRI looked like this. It's pretty normal. There's no tonsillar descent. The pituitary is not bulging out that much. You could argue that there should be a little more fluid in front of the pons, but this is basically a normal MRI. And so who were these images today? This is the first one, Kristen, the first patient that got sent to us with POTS. The images I was showing you. She also had this little bone spur in her thoracic spine with the contrast along this nerve root. Again, with the bone here contacting the exiting nerve root right there, where the dura is really thin. And this is what she looked like after getting her third patch. She now sends me Christmas cards every year riding things like motorcycles, which I disapprove of. But she's gone from being on disability to having a normal life. The POTS clinic at Stanford isn't used to seeing people with POTS just get better. And so they started seeing things like this, and a couple of referrals started turning into a stream of referrals. This is our gentleman with the bone spur at the top of his neck fusion, what it looked like with the contrast along the nerve root that they just see sometimes. His MRI was read as negative of the brain. Again, he could have a little more fluid in front of his pons, but this is basically a normal MRI. And this is what he looked like after his patch. He only needed one patch, and he went back to work as his former profession, which is as a game warden in South Africa. So this is him walking with one of the lions he raised. This was the patient that had their skull base opened up for Chiari surgery, where this was not called a leak. Her MRI shows the Chiari decompression here with the cerebellar tonsils being low. And that's what she looked like after getting patched. And the list goes on and on and on and on, mostly with imaging that was read as normal. And so what they had been diagnosed with was POTS, Chiari, Ehlers-Danlos, Tarlov cyst, chronic migraine, chronic fatigue syndrome, fibro. One of them was even diagnosed with Parkinson's disease. And so I call you to join me in trying to make sure that people who have leaks get recognized and treated. It is a tragedy when someone has something that cannot be fixed and we don't have anything to offer them. The tragedy is worse when we can fix them and we fail to do so because either we didn't connect the dots the right way, or we were too afraid to get the right imaging study, or we were too afraid to try and patch them. How safe is a patch? In the last 3 years, we've patched over 850 people at Stanford. That's incorrect. In the last 3 years, we've done over 850 patches at Stanford. Some people got multiple patches, so the number of people is low, but the number of patches is over 850. We've had no neurologic injuries. We've had no epidural abscesses. We've had no epidural hematomas. We've had a handful of post-dural punctures where we've accidentally caused a leak when putting in our needle to patch, and then we had to bring them back and patch them again. But it is a remarkably safe procedure, and you compare that to the risk of sending someone out of your office with a leak that you failed to diagnose, because if you're the headache specialist in your area and you miss this diagnosis, no one else is going to come up with it. You've consigned them to continue to live quite debilitated. So I keep a Google Drive folder where I keep resources for providers and patients. It includes a structured leak review of systems that you can ask people to go through all the symptoms that have been documented as being possible. You can take a picture of this with your phone. If you have an iPhone, it'll actually take you right to the website. So it's got a leak review of systems. It has something that we call a 48-hour flat test. So a number of these patients told us that they didn't feel better when they were flat for an hour or they were flat for 2 hours. They really had to be flat for 24 to 48 hours before they felt good. And since we tell people after a patch to be flat for 72 hours anyhow, everybody who comes to see me has to do the 48-hour flat test first. And it's remarkable what you see. You see some people who have not been recognized as having orthostatic headaches whose pain completely goes away when they stayed flat. But it's not always flat by the first day. The pain's not always gone. So we have the 48-hour flat test, the structured leak questionnaire, some good review articles, including one published in JAMA so that you can share it with your colleagues from a good, reputable source. and a number of the other articles that I cited in this talk. And that's all I have to say. Thank you very much, guys.
Thank you, Dr. Carroll. So I discovered Dr. Linda Gray and Dr. Carroll about maybe 3 years ago, and I have this thing where I love to go to headache conferences. I'm like at a headache conference every week in every country that I can get to because I always learn something. So when I come back, unfortunately, my office manager has to put up with me, and I always come back and I said, okay, now we got to do this. And I change the rules, make new rules, we make new protocols. But one of the things that we did after I discovered all this information on leaking, and if I'm right, Dr. Carroll, time's up. If I'm right, Dr. Carroll, a lot of what I've seen you say, and also Dr. Gray say, is a lot of these images were read by neuroradiologists that are trained, and they're read as normal, correct?
Yeah, and I think what it speaks to is when they're going through their training, they're seeing images like these, and they're getting told by their attendant,
this is normal. We just see that, okay. So yeah. Mm-hmm. Right. So when I came back from discovering all this, I came back to the clinic and I said, let's pull every chart of everybody who's never gotten better and see what's missing. And we found out they were all leaking. And there's actually 12 women on my staff, 90% of them have migraine, and about half of us are now leakers, we've discovered. So yeah, and the thing is, I joined the leaker support group, and I'm going to show you that in a minute. They're called leakers, which is, it sounds like you're either in D.C. working for the White House or you need Depends. We need a better term for that, I think.